Hi, it's Sunday morning talking about return to healing. And Alan, I wanted to talk about something that's not medical per se, but it's just how our medicine in this country is distributed. Because I saw this, I sent it to you, this little thing that popped up that said, of the 30 highest paying professions in this country, 23 of them are specialist doctors. And our friend, the cardiologist, we're number two in the whole country in terms of how much they're paid. So we're putting so much money of our healthcare system into this massive specialization that helps maybe no one, but at most a small bunch of people, while people are lacking basic access to care, basic health care, basic nutrition, not only advice, but ability. And one story that strikes me has to do with you, Alan, which is during COVID. Alan can tell it himself, but he was basically working in the epicenter, probably the
Correct.
world
Queens County,
epicenter
New York. Queens County was the
in your
epicenter of
center,
COVID.
and was in the hospital for 6 weeks straight. Got COVID several times. It was dealing with people though who are under the radar. And my friend and I looked at the COVID distribution of death because we wrote a book about it. And there were three areas in New York City that had massively high death rates, you being one of them. One was in Brooklyn, one was in the Bronx. And the whole rest of New York City, the death rate was like 0.1%. But in these areas, it was 10, 15%. Huge difference. And and I remember you telling me even that, you know what, these people have to go to work every day. It's not like they have money just to sit at home and wait this out. In my neighborhood, my area, we were dealing with a lot of tech people, a lot of teachers. They all just stayed home and worked from home. And I knew people who came home and said, "Wow, I'm living the dream. This is the best ever." But where you live, people didn't have health insurance. They have chronic medical problems that made them very vulnerable. They didn't have access to the foods. They had to go to work, so they're
Yeah.
basically bringing this around. What a difference! And
And
that disease showed
they
it
couldn't
to us.
just call Amazon to have their food delivered. It's a
Yeah,
different
yeah.
world. So I think there's three things, in my opinion, that contributed to it. One is, and unfortunately, you see it every time there's a fire in New York, like so many people die because there's so many people living in one tiny little apartment, or there's many illegal houses that, it's a two-family house that they break up into like 12 family houses, like there's two people in each room. So the living conditions are so close. The people need to get out to work. If they don't work, they don't get paid, and they need to get out to eat because if they don't get out, they don't get paid. And then, throw them on a bus or a subway and like that's it.
And I said at the beginning, everyone's yelling about solutions, and they paid a lot of money, the government, to keep small businesses afloat, because a lot of those businesses would have gone under, but they didn't pay any money to the people who worked in the businesses, and they didn't pay any money to the people you're talking about. Because I remember a few of us were screaming, we need to pay money so people stay home. We have to give them money to stay home, but it's like, yeah, we're going to give money to these business owners because they're much more influential than the people you're talking about, and they got just screwed. But to me, this is the whole healthcare system. This was like epitomized what we look at. We spend so much effort looking at whether this new drug for prostate cancer that costs $50 million a year for people to take, or for dementia, is going. We throw that on the market, and then all these other people, all they if they just had basic primary care, health care, nutrition advice, our longevity would actually go up.
Yeah,
But this little stuff's not changing our longevity at all.
it's not really the little stuff. It's the stuff. We
It's
know
the
our
stuff. Yes.
longevity is about our genetics, it's about our social situations, it's about environmental situations, and we saved this multiple times, maybe 10 or 20% healthcare, and like Andy always says, but that's when you're getting shot or something like that that we're saving you, but we really don't affect it. And when we don't invest, you know, the population health has proven that the only investment that really works in healthcare is primary care. And primary care that's based on wellness and prevention and keeping people healthy. And we don't invest in it. We spend double in our gross domestic product than any other leading country in the world for horrible outcomes. We're spending on drugs, we're spending on procedures, we're not spending to keep people well. And we have high rates of premature mortality. Multiple statistics show this. There's something called, what is it called? The subway map of healthcare. So, between the north side of Chicago and the south side of Chicago, by taking the train up down south, you lose 10 years in your life. And it's the same in the Bronx in New York, that, it's where you live. There's 10-year differences in healthcare, and it has nothing to do with the genetics. It has to do with poor people. And we don't address it. It gets poo-pooed. We give people Medicaid and things like that, but we really don't address the social drivers of health and the health-related social needs. And we have like the highest rates of premature mortality in underrepresented minorities, highest rates of maternal mortalities in the world, and infant mortalities in the world. It is disgusting, and it's like never talked about. It's under the rug. How can the United States of America have highest levels of premature mortality in underrepresented minorities, moms, and infants? How do we allow that, Andy?
How do we allow it also, and at the same time, brag about how wonderful our system is, and at the same time create that list I just showed you that shows you that we're investing our money in more in cardiologists than in diet, nutrition, prevention, changing the social situation. And no one's ever shown that this investment in cardiologists reduces death at all. May make people feel better because they have some new stents, but it doesn't, their cholesterol is great. They talk about it at the table. Well, that's all wonderful, but that you take that investment, you change that list and put primary care equal to all those other specialists.
Absolutely.
You change that list, people will go into primary care. And also back in the day, I remember when I was in college, I was doing a project on community health centers, and I focused on New York. And when I went to medical school in New York in the Bronx, I went and interviewed everyone who was running and some people who started the community centers. If anyone doesn't know, there's a movement started under Johnson, and it also trained, not only did it provide neighborhood-based community centers in some of the poorest areas, but and with federal money propping it up, but also trained people to work in there from the community. So a lot of the people I talked to had been trained to become health administrators and nurses. That money went to train people. Ronald Reagan dismantled the whole program in one foul swoop. It no longer exists. But those are the kind of, and then no one brought it back. So we're still with hodgepodge care. Just something that simple. I have never, Alan, heard anyone talk about because they talk about whether PSAs are useful, and we're going to spend $100 billion screening for skin cancer without changing mortality from skin cancer. But we are not going to even talk about investing money back into a system to try to give people decent care. And I would also venture, and this is based on statistics I saw from the Dartmouth Health Atlas, at the time when these centers existed, the average lifespan was actually as long or longer in these communities than in rich communities that see specialists all the time. In fact, there's a dichotomy between rich communities like in the center of Manhattan, who are constantly seeing specialists, and places like in Wisconsin where they don't, but they're not poor. The people in Wisconsin live longer. And the
Absolutely.
more specialists you see, the shorter you live. And that's also always, people say, well, they're sicker. That's why there's even more specialists. No, that's taken into account when they randomize.
So, so can you hear me still okay, Andy?
Yeah, so
I,
well.
I realized I was doing the first couple of minutes and my headphone and microphone were not plugged in. That's why I didn't hear you.
Oh, but
So,
I heard you though.
so yeah, so we call it the Dartmouth Atlas. The Dartmouth Atlas, you could go on, anyone could go on the Dartmouth Atlas, Google it, and just look at the price of, hospitalizations and healthcare in a place like Wisconsin or in a place like New York City. And it's double. So, and it's not just New York City, it's New York City and Atlanta and LA and Washington, D.C., places where they have a lot of academic healthcare centers. That's where the cost of healthcare is higher. And if you also look, there's the other dichotomy that you see when it comes to finances and things like that is if you look, rich people actually have more of a chance of having a complication from a needless test than anyone else because they're having needless tests. So, when you have a complication from a test that's not indicated, that's a really dramatic negative, in healthcare longevity, as opposed to if you have a negative from a test that procedure that might save your life. And so many people are having this useless stuff done. Every day they come up with a new one. I spent yesterday morning, to tell you the truth, before I went to the play, I spent, doing a little research on, mammograms and uh, cardiac
So,
screening picking up for an article me and Andy are writing, and it's just absurd. It's like, and these people are coming out and saying, this is really good. Like women now, like when they're 20, we could come up and start telling women they're at risk for coronary disease because they had a mammogram. And the disparities that we see is just unbelievable because then the poor people, they don't get the test they need. And then if you look at the other end of it, we really have a racist healthcare system. We know that there's a chapter or two in our book that talks about, how from the history of medicine, there's disparities and inequities, and it remains in our medical societies today. And certainly underrepresented minorities are not represented in the higher levels of healthcare. The lower levels, like home health aides and things like that, yes, because we abuse those people. But in the higher levels, like you don't see equal representation.
and a lot of it, the racial aspects of our healthcare system, much of our healthcare system is based on marginalizing one group and helping another. But when that marginalized group actually gets good primary care, they do better than the
Yeah,
other group. And a good example of that is the VA system.
absolutely.
The VA system is people scream, "Oh, you got to wait for things," but it's mostly primary care, and the longevity there is better than in any other system in
Yeah.
our country, and it's cheaper to run it also. So
And, and, and
specialists aren't making big bucks there, and
And
there
and,
aren't
it, and
many.
it's based on prevention. So I think my friend Wayne Jonas. So Wayne is a family doc who's spent 25 years in the military, and now his practice, he spends time in the VA and in the military bases, and he talks about military has a great healthcare system, and the VA does as well. And yeah, there's some delays in getting care, but I think they fixed a lot of that stuff now. And people in the VA actually get nutritional training, peer group training. They get excellent exercise training. They have access to massage therapy and acupuncture, a lot of non-pharmacological therapies. Like they're actually making smart moves of getting people there off of drugs and into more peer-related groups. And I think they're doing a reasonably good job if when you compare that to the rest of our healthcare system. Like my friend Wayne says, it's like, they all have the gold card as far as health insurance. Like they go in there and people care about them and they get good health care. And obviously, we know there's a very high level of underrepresented minorities, and they're getting really good care and they're living better and longer. So they've certainly earned it, and we should be paying for that, and they should have the best health care for what they've done for us.
But two, I think, well, although they earned it and should get the best care, health care, so should we all.
Mhm.
And that system or a system like it where it's predominantly primary care based, they reject expensive things. You have to get super permission before you start leaping down expensive roads. They're going to control costs because they have to, much like a lot of European democracies have to, because they pay for healthcare. And so they rein in some of this specialist abuse. And they also prop up the bottom, making sure to have good primary care prevents all the other problems that might occur. So they got the magic formula. Then why are we so reluctant to do that anywhere else in our healthcare system? Well, because of the profits.
Yeah,
To keep the 23 specialists up there, you don't want a VA system. They're not going to be up there anymore.
it's about profits over patients, unfortunately, and marginalized people, suffer more. Uh, Andy, so we could deviate and we could have another talk on this topic, but an article came out this week in JAMA about primary care as like a public good, a public fund, and kind of like you look at it, and I've been thinking about this all week, and I've been thinking about it on and off for a while. If we were able to separate primary care from the rest of the healthcare system and paid primary care providers like we should, and lowered the patient volumes, there was a fund to pay for it, family docs and primary care internists and, trained NPs, got paid what they deserved in an equivalent to an interventional cardiologist, okay, the world would be better. Everyone would have a primary care physician. Young, great doctors would want to go into primary care because they're going to make an equivalent salary and they're not going to have to kill themselves by seeing, 40 patients in a day. They'll have lower patient panels. And I think we should do a talk on that one, maybe next week or in a few
Yeah,
weeks.
let's do that because that is the crux of the matter and what we talk about in our book, which is, you're talking about a system of equal pay, and not only equal pay. You and I wrote an article about it in Health Affairs. Also, like you say, a reasonable autonomy. So we would take care of our patients and not have as many. So we can make phone calls, and I don't know if anyone knows it, but in our world now, because we are people doctors. Some of what we have to do is not when we're sitting in the office, and we don't get paid a dime for that. That they're, at least I think they say average 3 to 4 hours a day of unreimbursed work, and our reimbursed work is billed so low compared to what specialists can bill that it would just be a quick tweak. We have a solution in the back of our book.
Yeah.
Make that tweak, and yeah. So we should talk about it because look, that we know that primary care is what leads to longevity. Our system now doesn't. And the disparities of health during COVID kind of shows what happens when you have a system like this and you get hit by a catastrophe. Because guess what? In the parts of the world where they have a much more VA-ish system, they did so much better than we did. We had the worst outcomes in the world, and a lot of it's because of our system and the people who are marginalized.
And,
So
and and no one wants it to change except us,
just us.
we want it better for people. Look, me and Andy are, in the final chapters of our careers. We're not going to benefit too much if there's any drastic change anytime soon, because it will take years to fully implement any real improvement. But if we want to see the health of our nation change, especially in underrepresented communities, underserved communities, immigrant communities, you're not going to see it unless there's a change in how healthcare is funded and paid for. And or more importantly, or equally importantly, I should say, not more important, equally, you know, we have to pay for using your mind. A doctor shouldn't get paid more because he's making a little hole in someone's wrist or groin and sticking a tube in there. You could teach a monkey how to do that after a while. You don't need to train the most sophisticated doctors and give them $1 million. When me and Andy make life and death decisions, 20 or 30 times every single day, and get a $60 office visit out of it.
Yeah, we have to weigh all the complex parts of a people's lives and not just follow protocols like some of the specialists do. And then all the specialist mantra is, yeah, you need this test, which I could do for you. So it's self-referral, we call it. But
It is
it would be good.
self-referral.
What would be ironic, and that's what I was getting at with the community health centers that really were a tremendous program. And when I went back years later, it changed people's lives in a dramatic way, and were cheap. It was a cheap investment by the government into these programs. What would be great is to have a primary case community health network in a place like where you work,
Mhm.
and watch that the health outcomes, longevity, all that will be better in
So
that
we we
area
we've
than in
actually
Manhattan.
we've actually done it. We've actually I've just been accepted in the Annals of Family Medicine, where we were able to show. So we're a small community health center where I work in Jamaica, Queens. Jamaica, Queens is the most underrepresented part of Queens County. We have 2.4 million people, very high poverty levels. And we've been able to show by giving really good primary care in our 12 ambulatory care networks where docs are committed to caring for the underserved, because that's what they all do. And I've been doing it for 39 years, uh, that our outcomes are better. Our costs are lower. We have less ER visits and less hospitalizations between 12 and 15%. And that is a savings of millions of dollars. In our network alone, the savings is about $120 million that we've saved our hospital system by delivering good primary care. And primary care is the answer for everyone, but even more in the communities that we're talking about. We can make a difference in the longevity of people in this community. We can change infant mortality, maternal mortality, but we don't invest in it. It almost seems like it's not worth it to the people to invest. It's like really sad. It's really racist. Like it's so racist when you think about we have the highest infant and maternal mortality rates in the world in industrialized nations. Like, how do we allow that?
And you could take we wrote an article on racial medicine, and I wrote my thesis on it, but we have stuff on it in the book. But you can take a disease, and Isabella Wilkerson, who wrote some great books on race, including Warmth of Other Suns and Cased, was her most recent book. She says, look, we have this thing. Well, African Americans have a higher rate of prostate cancer, have a higher rate of hypertension. You have to treat it differently. She said, here's the irony: in Africa, they don't. They have lower rates of hypertension, lower rates of coronary disease. It's not race. We're attributing it to race, but we're taking people and putting them in the most stressful situation in the world, not providing food because it's too expensive to buy it, not providing primary care. So, when I worked in the Bronx, people's primary care was often the emergency room. And they would show up there in the middle of the night for minor things because that was the only chance they had to get it for free because they were in the margins of not having Medicaid and not having any insurance. If they started working, they couldn't take care of their kids. It was just a complex situation that when you fix it, like you said, with a tiny investment, you extend
Well,
longevity.
we fixed
Great.
it, but what you talk about, the use of the emergency room is still there because these folks aren't going to go into urgent care and pay for it. And
They're
everybody knows.
working and they're
Yeah,
working too,
right.
right?
So everybody knows you go to the ER in the middle of the night and you're going to get health care and they're not going to ask you for an ID card. They're not allowed to turn anyone away. And our ER does like 350 visits a day, half of them probably don't necessarily need to be there.
Yeah, so an investment in it, right? An investment in the system you mentioned, or like the community health centers of the 1970s and 80s would be an investment, unfortunately, Alan, that would prove that cheap primary care-based healthcare would provide longer longevity than the care being provided in Manhattan with these huge medical centers that are looking to find prostate cancers and give you radiation therapy because that's where their big bucks are.
Oh, a
And I
lot of
think that's
money in
where we,
radiation therapy.
oh yeah.
I don't know down in Washington, but they have like private doctors in New York that they advertise all over the radio. We have the highest prostate cancer success rates. We take all insurances because, even though the worst insurances pay well for radiation because,
Yeah,
it's
yeah,
it,
that's been negotiated to
it's a
do
profit
that.
driver. It's a profit
A
driver.
huge private driver. Oh,
$15 for, a family doctor or internist visit and, 50,000 for a good radiation therapy for prostate cancer that, will add 2 days to your life and make you impotent and incontinent. So it's, yeah.
2 days. Is it really gone up that high? I thought it was lower, but
Yeah, but then you have to wet yourself for the rest of your
you
life.
do. So those are not good 2 days you just added. That's one of the problems. Yeah, and it's the health disparity is that way too, right? It's a health disparity of focused on procedures and things that most people don't need. And unfortunately that's where we are now. So, okay, we will end there and maybe talk about some of the things that you've learned, especially, and we've both learned about how to implement a primary care-based system. And we could dig into our health affairs article because we had some ideas too. And it's funny, but no one talks about it. But this is where it is. This is the answer. so
They don't
simple.
talk about it because it doesn't make money.
Doesn't
They're
make any
talking
money.
about the next new drug, the next greatest procedure. Let's add $100 to the cost of a mammogram by, saying, hey, there's calcifications in there.
Yes, exactly. Yeah, I can't
How
wait to
many
read it.
mammograms are done? How much? The radiologists are up there. I know I saw them on the top of the
There were
list.
like three or four, and all they
Right,
do
yeah,
is they look at what AI says and write it down. That's
right.
all
Let's
they're
give them an
doing.
extra $100 for everything. But
I call AI radiologists scribes for AI. They're the
so,
scribes.
any young doctor, unless they're going into interventional radiology, that's where they actually do the procedures, folks. I think they're insane because AI could already read an MRI, a CAT scan, and a mammogram better than a human being. It's being shown clearly. So how that's going to continue to exist, I don't know. Well, probably because they have a strong college and
Yeah, good
a
lobby. They have a
strong
good
body.
lobby.
They're going to
Yeah,
fight it. They're going to say AI can't do it without us, and we refuse to give in, and they
that's
won't
what's
give
gonna
in.
happen.
But we
Exactly.
gave in, like us. We're the schmucks
We're
here.
schmucks. We're schmucks. We don't
Two
have a strong lobby.
two
We said
schmucks with a lot of schmucky colleagues.
exactly. Real schmucky colleague. Okay, Alan, we'll have a good um rest of the long weekend. I don't know. You're probably working Monday. I am,
No,
but
I'm off Monday, 4-day weekend. Happy
man,
Memorial Day,
that's
everybody.
insane. That's
All right.
insane. Usually you have a half day weekend at best.
That's it.
That's all you got. Okay, take care, everyone.